Hello, thanks for the opportunity to share the findings of our scoping review and crowdsourcing of RMC interventions and implementation evidence. I'm Dilys Walker. I'm an obstetrician gynecologist at the University of California, San Francisco, where I lead the Women-Centered Care Learning Network. This is a component of the Implementation Science Collaborative, which is one of the major products of the HERD project. And this is Implementation Science Collaborative is an expandable partnership that can be rapidly mobilized to support research, evaluation, and country support needs. Today we're going to talk about RMC interventions, and I don't need to tell you that the prevalence and etiology of disrespect and abuse in childbirth has been documented and interventions have been developed and evaluated. However, stakeholders such as yourselves lack information and evidence to understand which interventions should be implemented. So we set out to identify and summarize the breadth of promising approaches and existing evidence on RMC interventions and programs in Africa. We wanted to identify and describe a framework that might aid implementers in making difficult programmatic decisions. We found a total of 43 unique efforts that were distributed across 16 African countries and implemented between 2009 and 2020. These 43 distinct interventions were concentrated primarily in East and South Africa, with the highest density in Tanzania. We can see in recent years there has been a fairly rapid increase in publications and documentation of RMC promoting interventions. We looked at where in maternity care do these interventions act, and we found of these 43 approaches, there were 16 that just acted around the time or were addressing or focused around the time of childbirth, but many of them actually included pregnancy, childbirth, the postpartum period. Some of them even included newborn care or family planning in terms of promoting respectful behaviors and interactions. We then set out to categorize the types of approaches, and we took is the approach a supply side target or a demand side target? By supply side, we considered things like training healthcare personnel, facility level improvements, and we put things like educating birthing people, engaging community members on the demand side of the equation. We found that of those 43 interventions, most of them were not single approach. Most of them took multiple approaches. However, most of those that did take single approaches, and by that we're looking at the green bars, 80% of those are supply-side interventions or supply-side approaches. And of the multi-component approaches, 71% of those also combined both demand and supply-side interventions. So this sort of categorization as supply side, demand side gives an idea of where they might be acting, but it doesn't really help an implementer decide or think about how they might be acting and how there might be different drivers or pathways for action. So this is where we decided to look at what might be a potential framework that could guide the design and the selection of interventions for a health system. And we, after looking at many different frameworks, we landed on a behavior change framework. Many of you may know the COM-B model, and we applied that to RMC promoting interventions. Now, the COM-B model is based around the theory that any behavior, and in the context of respectful maternity care, we see that behavior as the interaction between the provider who works within a health system and the patient woman and her family. And each behavior is going to be impacted by capability, motivation, and opportunity. And by each of those, the components are capability, which means things like practical skills, knowledge, education, awareness. That's your capacity to actually do something. Then there's motivation, and these are sort of reflective processes or assumptions about people, beliefs, code of conduct, belief in the basic rights of childbearing women. And then opportunity includes things that are physical and social opportunity. What are the factors in the environment, such as availability of supplies or curtains or water or electricity, that will promote that respectful, dignified, kind care that we're trying to promote? So if we look at it as this behavior change that do each of the interventions to date, could we map them onto this kind of a behavior change model rather than a supply side, demand side? How can we map that into something that would provide a pathway for change? Now, the behavior change model, the COMBI model, can be transformed into what's known as a behavior change wheel. And we took our 43 interventions and we mapped them into those that address capability, those that address motivation, and those that address opportunity. What you can see that they're fairly well distributed across these behavior change pathways. They're also, interestingly, fairly well distributed to date on those that act at a community level, those that act at the facility level, and those that act at the provider level. So what is important about this is that it may give implementers a sense of, if you're selecting a menu of interventions, you may want to select interventions that provide some diversity of impacting different pathways to behavior change, including whether it's capability, motivation, or opportunity, and not just focus on those that are motivators, but you need to include other components. Now, when I say you need to include, that implies that I know that that's the right approach or that will lead to improved behavior. And that would be a conclusion that is not based on evidence. What do we know? We know that some of these interventions have had measures, have had evaluations, but they're quite diverse. They may target measures related to providers and the provider's knowledge or behavior, indicators, measures related to women giving birth, which I think is an important focus because that in the end is what we care about most. And then those that are at the facility level. Does it measure counting curtains and water and toilets if that doesn't impact directly the measure of the woman's experience of care? So I wish I could tell you what works, but I can tell you that there is not a lot of consistency in measurement and not a lot of conclusions that can be drawn to date. So what are some conclusions? Most interventions include provider training. They include multiple approaches, which is encouraging to see that diversity. However, there's a lack of specificity on the intervention components and how these implementation efforts are carried out, and limited and inconsistent use of metrics. In terms of recommendations, we recommend that those selecting interventions ground, design, and describe them in some sort of framework that makes sense, such as the behavior change framework, and we felt that that was a useful way to map the interventions that we had identified to date. We recommend the use of innovative tools and delivery mechanisms beyond training or within training. We need to more clearly describe and document the details, particularly of training interventions, because there's so many different approaches and doses and frequency, and we really don't know, or we don't have much in the way of evidence of what works. And I do urge everyone to leverage implementation research to better document and more consistently evaluate, particularly these combined, more complex approaches, and use consistent measurement with shared indicators to understand both impact and progress. And I like to end this with just an acknowledgement and thanks to our supporters. Thanks very much.